sucked because I was like, oh, I don't want to do this, but I was like, it was worth it. And so, she basically put the focus back on Jim Wood. She was like, Jim Wood, we need to focus, like he needs, we need to put some pressure on him to hear the bill, because he's, not, not thrilled about it. And I asked her about Gavin, and I said, is he, what's his temperature like? Because I know he feels some kind of way about us going around his little commission.
Yeah. We are, like, let me just say that we are live. So
all right, we're live on Facebook.
Live on Facebook, live here. Steve, welcome. We'll give a few more minutes before we get going. Maybe I'll share the graphic, that graphic.
Yeah. Oops.
And yes, this is CalCare office hours, sponsored by I'll reintroduce in a second, but by Healthcare for All Los Angeles, Physicians for a National Health Program, Southern California, and the Progressive Democrats of America. And let's give it a few minutes.
Yeah.
I'll stop.
Facebook has recognized me as a Healthcare for All Los Angeles top fan. I'm also a top fan for the LA County Department of Public Health. That lets you know where I spend a lot of my Facebook time, people. When you're a top fan for the Department of Public Health, that says a
lot. Does that mean you don't have a life?
No. That also means I dedicate a lot of time to like paying attention to what public health is doing. So separating fact from fiction, going and finding sources to fight misinformation. I think that is what another thing, the misinformation train, like retrospectively looking, I was with, spoke on this past week with, I was asked to speak with the People with Dave and Fam, which is a show that's on Saturday mornings on KPFK. And we spoke, and I was speaking with a microbiologist, Dr. Francis Tran, and we completely nerded out for an hour on the COVID vaccine and COVID, and it was just such beautiful scientific, just wonderfulness. To have, to be on a call with the scientist and me to be so deep into the science. And to, we talked about the misinformation, and it was just really a beautiful thing. It's just so good when you get around, like-minded people who really get into the nitty-gritty of the science, and I can nerd out and enjoy it and be proud of my nerdiness. And then I had to give a caveat that, I had to say, hey, not all nurses nerd out to this level. Like, I have a slight obsession. So don't expect this level to come out of all I do not want to set up my fellow nurses to think, that we all nerd out at this level. I'm like, I definitely have taken it a little further. All right, I digress. I'm sorry to everyone watching, but that was just a funny story. But yeah, if you have time, The People with David and Fam, PHAM as in Mary, is on Spotify. And this latest episode was with myself and microbiologist, Dr. Francis Tran, where we really took a lot of, went kind of deep into COVID and the COVID-19 vaccine in the community. So it's probably, I had a lot of fun doing it. I don't know if it sounds fun because we really got deep into the science, but yeah.
I mean, to me, that's fun. And it's a reminder too, that like, we're about to do our thing here. And, we like the people here, we're interested in health policy, but most of us, like, that isn't where we started when we went into being a nurse or a doctor, right? And there's a certain part of you that's like, God, if the whole system was good, we could actually just focus on this other set of things we love, which is taking care of people and the issues around just those direct issues, right? Like, what do human beings need who are in front of me or the public as a whole, right? And it's not, not that we dislike this. It's important, but it's, you can think about this work as getting around things that are in the way of the real work, right? So one more minute, I see. Let's see. We'll launch. We're going to be here till 7. By the way, Paul, were you able to also peek at questions on Facebook by any chance?
No, I haven't. I just popped on. A friend of mine who lives in Thailand was in a scooter accident,
Oh,
and he's a lifelong friend, and I know his brothers, and so they just contacted me. So I didn't get a chance to do anything.
no. Well, I mean, but would you be able to if we want?
Yeah, I'm happy
peek
to.
at that just and see, and we'll keep our questions flowing from both sources. So
Sure.
and well, let's start. It's 5:05. So welcome to the group that's here and on Zoom, but also welcome to people who are watching on Facebook Live. This is AB 1400 CalCare office hours. I think it's our fourth one. Is that right? I think it's our fourth one. We're doing them every week. And what's the purpose? So and who are we? So in late February, there three assembly members headed by Ash Kalra introduced into the legislature on the assembly side, AB 1400, the Guaranteed Healthcare for All Act for California, which would create a healthcare system called CalCare, a single payer system for the state. And that's a big deal. And we're excited about the prospect of that. And also aware that there's an ongoing need for people to learn more about what that means, what a big change in our healthcare system this would be. And that's what we're here for. The we today is Healthcare for All Los Angeles, Physicians for a National Health Program, Southern California chapter, and Progressive Democrats for America. And I'm going to ask each of there's two other hosts, Jeanna Harris and Dr. Bill. I'll mostly try to just steer questions and that kind of thing, but let me ask you to self-introduce. So our next speaker is Jeanna Harris. Jeanna.
Aloha, everyone. Welcome to office hours. It's a little steamy here in Southern California today, which I love it. I particularly am very happy to have the heat back, but I'm hot right now, so not cool. Anyway, I'm Jeanna Harris. I'm a registered nurse, and I am very, very obsessed with CalCare. I have these issues with going into obsessions, but have been always wanting to educate and help advocate for my patients and the community. And I've done that through my political work and as well as at bedside. I'll tell you that I was lobbying patients for SB 562 at the bedside as I was telling them what benefits they didn't get covered. So there's nothing better than to galvanize a community when you're telling them that their benefits don't cover it something, you know what I'm saying? So with that being said, I think that a lot of people already know me, LA CDP member, Bernie delegate, et cetera, et cetera, et cetera. But most importantly, I am an advocate for the people. So that's about it for me. And I'm going to throw it to somebody else you probably already know, Dr. Bill.
Thank you so much, Jeanna. And Dr. Ron Birnbaum, you are both heroes of mine in the movement, and thanks everybody for joining us today. I'm Bill Honigman. I'm a retired emergency room physician, and I want to pick up on what Ron was just saying, which is that when we went into medicine, we didn't do it to become healthcare advocates. We did it because we thought it was a respectable way to make a living, meaning that it was a good thing to be. People respected you for the work that you did, and it paid well enough. And I think that what happened for a lot of us was that we ran into this brick wall of corporate profit first interest groups, especially big insurance, big pharma, but also big hospital, big organized medicine that said to us, you can't practice the medicine you want to practice. I even before I went to med school, I went to UC Santa Cruz and took a class because I was thinking I was pre-med. I took a class on the sociology of medicine. and I learned about a whole lot of this stuff. I also learned a lot of stuff from my father, who was a family medicine doctor in East LA. And I would just help him do his billing, and I could see the difference between commercial insurance billing versus Medicare and Medi-Cal billing. And I just said, this is insane what we're doing. I ended up working for Kaiser for over 30 years. And I'm just really happy to join you because I know a lot of people have questions about Kaiser. How does it work with a single payer system in California? So I'm really just here to answer some of those questions. Also, hopefully I can show you a couple of slides on the economics as well, especially with a little bit of history and background in the California efforts we've made in California for single payer bills over the years. So thanks for having me.
No, of course, so delighted to have you. And so let me flip back to Jeanna for a second to just give us a little bit of direct intro on the bill itself, and then we'll cycle back to those things you wanted to share.
All right. So yeah, sorry, I didn't know. I wasn't sure if I should do it right when I introed myself, but so let's talk about CalCare. Enough about me and everybody, but let's get to the nitty gritty here. CalCare, guaranteed health care for all. What does that even mean? Well, thanks to CNA and NNU, which is the California Nurses Association and National Nurses United, who are very strong advocates for this bill and have always been with us lockstep every step of the way as we've been trying to advocate for reforming and just, I don't even want to say reforming because our current healthcare system can't be reformed. It is mostly just, we got to rip it up and just completely re-sew it back together in a more equitable way. So let's talk about the 7 basic principles. We love this slide because it just encapsulates everything we're fighting for right now, which is number 1, universal coverage, everybody in, nobody out, regardless of your age, your gender, your country of origin, you're disabled, your immigration status, your marital status, age, income, you get the care that you need. And that is the whole point. And, that may sound expensive, but it's even more expensive not to cover it. So a single public program, publicly funded through progressive taxation, which means, yes, if I make a certain amount of money, I pay my fair share, but guess what? So does Bezos, so does Elon Musk, so does, Bill Gates, any of these billionaires. I think there's about 160 that are in California alone. They get to pay their fair share of taxes too. Fair is fair. I pay mine, you pay yours. We're all living in harmony, right? That's why we have to rip this up and sew it back together, because right now that's not working. So anyway, we're going to eliminate billions of bloat, administrative costs, people wanting to charge this over here, charge that over there. I get to charge a little bit more because I'm in UCLA, but I can't charge the same amount because I'm over in a small hospital in Monterey Park. That's going to go away. We can't have that. That ain't right. So we're talking full comprehensive benefits. If you notice, Medicare only covers everything from the neck down. Like you can't get dental, you don't get vision, you don't get a lot of stuff if you just have the original Medicare. But this covers medical, dental, vision, hearing, prescription drugs, long-term care, very important. And the decisions of your care will be between you and your doctor or nurse, not the insurance company. No more gatekeepers, okay? You should not have to go and fight the gatekeeper to get that treatment you need. If you medically need it, and you meet the criteria, you check the boxes because you're sick, guess what? You get the care. No more, well, we're going to route it this way. We're going to send it over here. Are you sure they really need it? No, you're going to get your care. Freedom to choose your care provider. A lot of people are concerned about that. You do not like your insurance, okay? I haven't met one person that can tell me why they like Anthem. Why do you like Anthem? The first thing they say, well, my doctor. Well, guess what? You don't like Anthem, you like your doctor. Your doctor's going to stay with us, Anthem's not. So there's this separation here, okay? We're free at the point of service. When you go to your doctor right now, you got to pay a copay. I have to pay $25 just to walk into my doctor's door. Guess what? I'm not going to have to pay that $25 anymore because no more copays, premiums, or deductibles. If you get through Covered California, the Affordable Care Marketplace, you may choose a plan right now that is the most affordable to you because you can only afford $100 and something a month, which is absolutely ridiculous. But guess what? You still have a $6,500 deductible. I'm quoting actually real numbers from the Covered California Marketplace right now. Actually, I took that it was $263 for me. That was the cheapest, $263 a month. And that was with a $6,500 deductible. That is insane. For me, and that's just me as one single person. I can imagine what a family would be. It's ridiculous. Once again, why Covered California doesn't work. Just transition. So people who might work in the insurance industry, hand up right here, we're going to be transitioned into somewhere in the system. I'm okay taking my little managerial admin skills and going right and doing something with CalCare. I'm okay with that because one thing that this is going to do is take so much stress off of me, not having to worry about the financial part of this. The financial part is what is so stressful to me, having to always know that I'm pushing people, we're having to direct or expedite care, not because it's important for you, it's because it is important to the bottom line. And that bottom line ain't you. Anyway, lastly, patient care based on patient need. Why do you like we need patient care based on patient need, okay? Which means that you get the care that you need, not the care that we want to pay for at the time. And that is the 7 basic principles of CalCare.
So thank you for that. It's there are a lot of details, but at some level, it's a simple thing, which is one of its virtues, right?
Just give people healthcare. Healthcare equal productive people. Productive people help, what do they care about in the stock market? The GDP. I didn't learn about GDP in high school, by the way. So I think that's what they care about. So if you have healthy people contributing to the economy because we're working, and guess what? When we get paid, we don't go put our money in the stock market, which Elon Musk and Bezos do. We go make it rain at Target. So that's stimulating the economy, So you want us healthy, rich people. You want us healthy. And I'm done. Okay, I'm shutting up. I'm muting myself. I'm shutting up.
You're good. And of course, questions coming. But so Dr. Bill, your perspectives on the bill and how it connects to some of your experiences, and then we'll hit our questions.
Well, first and foremost, Jeanna, do not ever shut up. Do not ever stop speaking because we need your voice. Absolutely. And also, I love your take on the just transition because we need you doing effective work, not paper pushing, not blocking people. We need you as a care facilitator, somebody who gets people what they need in healthcare. If they need, diabetic testing kits and prosthetics and, whatever they need. So we need to take all those bad jobs currently in health administration and turn them into good jobs that get people the healthcare that they need. And we're going to need lots of those people because we're recovering a third of every healthcare dollar that is currently wasted. And, I got a couple of cool graphs I want to share with you, and that's it. And then otherwise, we'll open it up to folks because I know people have comments. That's really why we're here, right? To take comments and questions. So, but let me just share with you a couple of concepts. That's really what I thought I would like to do today. So first of all, we know that that this is not only true. Dr. King was so right about so many things, that injustice anywhere is a threat to justice everywhere. COVID-19 has taught us this is absolutely the case in healthcare. That injustice, healthcare injustice anywhere is a threat to justice everywhere. So we need to have healthcare justice and health equity everywhere. And there's really only one way to do that. And that's to take it out of the hands of commercial interests, because they don't get into things unless it puts money in their pocket. And that's immoral. It takes money away from the public need and into somebody's pocket when there's still a public need for those resources. But I want to share with you some of the economics. And, this is a chance, COVID is a chance for, otherwise well-meaning lawmakers, like you mentioned, Assembly Member Jim, what's his name again? Up north? The head of the health
Jim
committee.
Wood.
Jim
Wood.
Wood. Jim Wood, yes. Or Speaker Anthony Rendon, or President Joe Biden, for that matter. This is an opportunity. COVID is an opportunity for them to follow the science, not just in epidemiology, okay? Follow the economic science. So here's an economic feasibility study that was done for one of the first single payer bills that actually made it all the way through the California legislature and then was vetoed by Arnold Schwarzenegger back in 2004. And this shows the tremendous savings. See, it's kind of an upside down horseshoe. If you look at this, the graph goes down. See the way the bars go down from the zero line? That's because this shows savings to business groups, small, medium, and large business groups. Now, you take a school district, for example, they mostly have 500 or more employees. Most cities, good sized cities have 500 or more employees. They stand to save, this is probably twice that figure now. It could be $5,000 or $10,000 per employee per year. This study was done by an independent financial analyst group called the Lewin Group. This is not some commie left-wing, University of Massachusetts progressive sympathizer, Jerry Brown, sympathizing group. This is the Lewin Group, very well respected. That's why it was picked by Senator Sheila Kuehl back in the day. Everybody said the Lewin Group said that, and the eyes lit up at this kind of savings per employee per year. I mean, everybody running for city's council or school district should have a position on this bill, on AB 1400, because they stand to save that much money per employee per year. And I guarantee you, when we redo these figures again, and we will, it will be much higher than this, and especially now because of COVID. And then I want to share with you this graphic. This is, we call this the spaghetti graphic, or spaghetti on the wall graphic, is the way I like to refer to it. It was done by our friend Henry Broska, who's a health systems analyst. He's originally from Canada, but he lives here in Orange County. So he developed this graphic because he was astounded when he started to look into how many healthcare agencies there are in California just to process one healthcare claim. So your bill is paid for, it starts here and it's paid for here. And one of these is the Canadian system, the other is the American system, how we pay for healthcare. And, I think you can tell which one is which, right? So the hint is down here. It says provincial payer. They have provinces in Canada. We don't, we have states. So this mess right here, our friend Henry Broska says, is actually 4 or 5 layers deep. He couldn't fit it all on one page, but these are actual agencies that exist, in California as well as across the country, that, doctors, hospitals, clinics of all kinds, even if you just go for some lab tests, you have to go through this morass of administrative, complicated mess. This is not just waste. It's also an opportunity for fraud and abuse. This is where all the backdoor deals go on between insurance companies and doctors and hospitals. And this is the mess that ends up with surprise billing when you come out of the hospital. And it's also an opportunity for unscrupulous predatory pricing based on an extortion model, business model like the mafia that says, what's your life worth to you instead of what does it cost them to provide the product that they're offering. So we need to get rid of all that. And that's what this bill does for California. AB 1400 does for California, just like the National Medicare for All Act will do. Thanks. I just wanted to share those two graphics with you. I think they're pretty powerful. And then otherwise, turn it back to the group for discussion. Ron and Jeanna, thank you so much.
That's
the spaghetti plan. The spaghetti plan makes you shows you like exactly why the system fails. Because imagine you being, it reminds me, if you guys remember those little, like, what is it, you color by numbers things, and you would have to follow the numbers and all that stuff to kind of, so imagine being that patient and you're just on one of those lines. And let's say you don't have an advocate. Like for me as case management, we're kind of your advocate if we know you exist. Sometimes, most of the time, a lot of patients, we don't know you exist. We only catch a small percentage of them. And so, you have to navigate through all of that on your own. And most people can't. They usually get stonewalled, stopped somewhere on that plan. And then their care gets worse. They get sicker and probably die. Lost in the spaghetti. So we're trying to clear out the spaghetti. We're trying to clear the plate here. And make it a little bit cleaner so that patient doesn't get lost in the spaghetti. Exactly. All right, let's go to questions.
Yeah. So
a whole lot cleaner.
James Sarantino, colleague, friend, question.
Indeed, yes. So the other day, Maureen Cruz mentioned there was a certain number of agencies, like a minimum number required to process one Medicare claim. Does anyone know what that number is? Because I'm giving a talk at a neighbourhood council, and I'm just trying to very easily encapsulate the stupidity of having so many payers. Does anyone remember what number she mentioned? Was it like a dozen or something? Or does anyone remember what I'm talking about?
I think I remember her talking about it, but I don't know that number offhand. I could tell you that it's about 200 to 1. Those two systems that I showed you for processing claims, it takes about 200 American claims processors compared to the work of one claims processor in Canada. That's the degree of complication. Like, for example, you take a pretty big hospital, like say a university hospital, UCLA, or say one that's not directly a public hospital like UCLA or Cedars-Sinai or something, that has maybe, I don't know, 600, 800, 1,000 beds. That could take in this country as many as 1,500 or 1,600 people in their billing department. In Canada, it takes 8 people. 8 people to run a billing department for a 1,000-bed hospital in Canada, where it takes 1,600 people, in this country. So that's what we're talking about, a tremendously inefficient system in this country. And that's where you get the savings. You pare it down, you make it simplified, standardized, unified. That's what they're calling single payer now, is unified financing. You do all that, and it becomes tremendously more efficient. And that means you transition those jobs, as Jeanna said, you transition those jobs to ones that are actually effective and get people healthcare they need, rather than mindless, ridiculous paper shuffling.
And just a very quick point. I just saw an ad before I got on this call, advertising nurses for $13 an hour through an agency. So we need to tell all the nursing students, that's not going to happen with you guys anymore. It's insulting.
13? That's like student. That's not even student. That's CNA like level. That's less than CNA level. Well, in California anyway. $13 an hour would be maybe CNA level where I'm from in Indiana. When I first started as an EMT, I was making about 11 an hour as an EMT. And just shout out to the medics and the EMTs, grossly underpaid, and they are really like doing some miracles out there on the streets. I give them shout out because I learned how to start the best IVs from an Army medic / paramedic. And that's when I learned, Dr. Bill, how to drop EJs. I learned from them. You're dropping one of those in the ambulance going 80 miles an hour. That is a true talent. And they get so underpaid. Actually, that was what stopped me from being a paramedic and going into nursing. Was because literally the pay gap is so huge that in the same amount of time almost that you have. Sorry, I got muted.
No, I did it back.
Yeah, the same amount of time almost for education wise, like where it took me to be a nurse versus become a paramedic. And I make probably close to $50,000 more. So that's how crazy the disparity is between medics and nurses. Not saying that nurses, like, we definitely do a lot, but I just had to give that little shout out to the medics because I love them, big heart. And, I learned the most from them compared to, not from throughout nursing school. I think I learned the most from my medics. But just to add what you were saying, James, really quick, when it comes to the billing part, so, I like being on my side, when a provider submits the claim, it goes through our internal claims department because we're a payer. So it really stays internal. The payment comes out from my company because we get Medicare monies and plan monies dumped into our pot. We're trying to stop that and say we want to just dump into one public pot instead of just instead of each individual plan and everything gets their own pot. So we pay out the claims, but we're so petty that you don't code right. You don't include that 100.37.2 and you put 0.1, that $50,000 procedure, guess what? It gets denied. And I don't know how many times I've been hemmed up by specialists, almost like when I was rounding in the hospital, almost like grabbed me by my little white coat, because I actually got a little white coat, so it was kind of cute, and hem me up and say, they didn't pay me. And I'm like, I'm so sorry, but I don't have the access. I was like, I don't have the credit card. You know what I mean? And literally they would threaten, I'm not seeing your patients anymore then. And guess what? That delays care because now I don't have that surgeon or that provider to see my patients because they don't want to see my patients because we didn't pay them. And when I go back to the claims department and say, hey, this doctor didn't get paid, we need to pay them so they see my patients, they're pissed. They're like, well, they need to resubmit the claim. And that means starting the process all over again. So you see, here goes back to the spaghetti.
And yeah, and well, let me just say one thing about that. Sorry, which is that the Medicare, pure Medicare, traditional Medicare, that has a reputation for paying, just people get paid. It gets more complicated when the insurers become involved, which is the features of
because
Medicare.
We're not paying at Medicare rate either. So we're usually negotiate lesser than Medicare rate. So that's another thing. They're not even getting paid fully what they should. So, that, and then we're not paying them on top of it. So imagine the insult for that provider,
So I want to go to the next a question that was in Facebook that I think it came from Sean Broadbent originally.
Hi, Sean.
So it was this. So friends have been expressing concern about the long-term effects of COVID. They need a lot of help to understand how to live healthy given the unpredictable effects. How could CalCare help people who are COVID long haulers? What are the barriers currently?
You,
Bill?
well, I'm happy to chime in.
Yeah.
So CalCare is the opportunity to help people with chronic conditions of all kinds. It's also, of course, preventive medicine, heavy. So it emphasizes primary care, which could prevent some of those conditions. But, through no fault of your own, you end up with COVID that gives you long hauler syndrome. You're going to need lots of care and lots of support for that. And way beyond just doctor's office visits, you might need, physical therapy or occupational therapy or, other kinds of support services. That's built in to CalCare. You have no guarantees of that when if you're just dealing, with these things independently on your own or through commercial profit first insurance. So this is a chance for the public to prioritize needs, and that's something we all recognize at this point as regards this new epidemic, on our shores, or pandemic, globally, that we've got that public need now. How are we going to address it? Well, we failed miserably, as everyone saw, in terms of testing, contact tracing, providing adequate PPE and equipment, at the very beginning of the pandemic. So now that people are impacted, whether they died, which is horrible and inexcusable, or ended up with a chronic condition, all of that would be made better in California with CalCare. And so it's just part of the whole spectrum of care that's made better with a plan like this that would be in control, it would be controlled by we the people instead of the corporate entities.
Thank you. So a next question that I want to hit, and that is also from Facebook, relayed by Paul. Paul, by the way, thank you, brother, for monitoring the Facebook chat and relaying those questions, and that's important. And so thank you for that. So it's from Lou P. Cruz, and Lou P. Cruz says, I have a question. Teachers in my district, so she's a teacher, pay into a supplemental health care plan each month, as well as our regular insurance. This supplemental health insurance covers our medical bills after age 65 and up. I've been fighting for health care with others, but my union is fighting against us. If AB 1400 passes, what will happen to our dollars in our supplemental health care plan?
Well,
Eric, go ahead. Yeah.
I could take that on again. So
Go for it.
So any negotiated benefit through an employer or otherwise, needs to be renegotiated. When you have something like this, where the fundamental conditions of that negotiation have changed. And that's part of the National Labor Relations Act, which, due to the supremacy clause of the Constitution, dictates what happens across the country. So for California to, implement a plan like this, it would be renegotiated. Now that means that, first of all, you won't need any supplements anymore. So where does that money go then? Does it go back in your pocket? Does it go half in your pocket, half in your employer's pocket? I don't know. It depends how the original negotiation was made, with as part of your benefits. When you retired or left, or if you still work there for that matter. So that's written into the bill as something that the CalCare board will address, once the funding is in place and the board is in place and all of that. But it, by law, it will be addressed, and there will be something that's equitable and just as a resolution to the problem.
And let me throw in a couple other things, which is CTA has just endorsed AB 1400, or I am informed of that by Paul Newman. Is that that's one thing, and that it, as Jeanna mentioned, it was introduced also by CNA, which also is a union, which I can't speak to their specific benefits with relationship to supplements and Medicare. But one thing too that I would encourage, Luke, if you're out there, is to look in the bill, and we can connect people to this, at the list of benefits, and that will help you get to why the need for supplements would generally go away. And it's a separate question, what happens to that pot of money? And Bill answered that. So
can I just add one quick little thing? Is a great friend of mine here in Orange County is the chair of the Orange County Democratic Party is a terrific person named Ada Briseño. She's the president of Unite Here Local 11, I believe it is, and is a steering committee member of the national group, the Labor Campaign for Single Payer. So they look at single payer type of reform, healthcare reform across the country, which would include our bill here in California, CalCare, AB 1400. So you might check out their website, Labor Campaign for Single Payer, and or contact Ada Briseño. She's, like I said, the chair of the Orange County Democratic Party, for more information as regards how labor will respond to those changes. Thanks.
And Cynthia, you brought up Ada. So, she spoke actually yesterday at my speak out, the CalCare speak outs that occurred yesterday. I was at one in Culver City, and she spoke there. And she brought up the key point that I drive home with the unions. Unions spend most of their time at the table fighting for healthcare benefits, when they should be actually probably fighting for something else, like your safety. The nurses, our safety is always under, kind of under threat, because even though we think that in the hospital you're safe, you're actually not. You really don't know who you're taking care of. I've taken care of everyone from Aryan Brotherhood to, all types of people. And you just don't know what will happen in that room. And, but we spend so much time fighting for just the basic healthcare benefits. And with CalCare, and, Ada, it basically said the same thing. That goes away so that they can focus on your your pay and your working conditions and everything else. But right now, healthcare is taking the precedence on these labor discussions, and then it becomes pay, and everything else falls underneath that. And for example, for the teachers, why the hell are you guys having to bring your own crowns and paper for the students? Why is the schools not doing this? What is that about? And so if we take healthcare off the bargaining table, we don't have to worry about that. You're already covered. Now we're going to go focus on that question of why the hell are our teachers having to go buy the crowns and the pencils and the tissues? Granted, I'm a millennial, but an elder millennial. Okay, I'm in my 30s, so I'm an elder millennial. But when I went to school, we had to get school supplies, but I never saw a list where it was like, oh, if you can bring supplies for students who can't afford them. No, because that was already supplied. We already got the basic crowns and paper and stuff. And I was just kind of like the stuck up one who wanted the 64 count box of crowns. So, that's what my parents had to pay for. But, that type of stuff, when it comes to unions, because I've heard this question come up more than once about, benefits and the union, some unions not being on board. Like I said, it takes so much off the table when you don't have to worry about it, and allows you to go fight for the things you really need to be fighting for. And I don't see why one union would not want to be on board with that.
And if we want more money for schools, pass CalCare. That's the way you get money for schools.
Absolutely. So there's another question from, Lynn, do you want to just say your question, or do you want me to read it? Whichever you prefer.
No, I can say it. Thanks. This may have been addressed. I've been watching hundreds of Zoom meetings about single payer, and 1976, 1400. This question may have already been answered. Is a study like Perry being done for AB 1400? Bill's nodding his head.
Yes.
Is it Dr. Pollan again, UMass?
I have not heard who's doing it.
Great. So we got one other question. How do you think the bill is going to do on the 21st, which I understand is the Assembly Health meeting?
So we're still kind of up in the air. Right now, the bill is sitting in CHBRP review. Okay, so any bill that repeals a health mandate has to go through CHBRP, which is the California Health Benefits Review. I just like saying CHBRP because it says burp. It has to go through that. That's part of the rules. We didn't know that until a few weeks ago. But, it has to go through this review. It's due to come out on the 21st, actually. And so, or the 20th or 21st. And then it has to go into the health committee. So I don't think it will make this health committee meeting on the 20th, and should be heard on the 27th. If it's going to be heard. And that kind of, just let me caveat right now, like I'm getting advised by, Sydney Comlager. I don't know if I should have said her name, but oh well. She's a co-author, so she's down the ride with me. We're riding to the very end on this bill. And so, we need to be reaching out to the chair, who's Jim Wood up in District 2, who may not be the darkest shade of blue. I'll just say that nicely. And we need to reach out to him and let him know that we want this bill heard during this session. If not, it could be possibly heard on the next legislative, session, which will be in 2022. So we need to really reach out to Jim Wood and he's the chair of the Assembly Health Committee, and tell him, like, don't be petty. and hear it in the health committee. That is my saying, don't be petty, and hear it in the health committee. So that's kind of the goal in the next couple week. So we want it to be heard. We want it to, definitely get there. But, I think we actually quite a few of the co-authors and sponsors are actually on the health committee, which is very promising. But we know that it definitely, Jim Wood holds a lot of that weight. And so we definitely want him to know that we are wanting this bill. The people of California want it, and we want it heard, and we want it to get its fair shake. And I drop his information in the chat here. Let me go dig it out.
I threw the website, but we could get deeper and get the digits up. So that was quick. But so the hand I see up is Healthcare for All Los Angeles co-chair Erica Ferriston. Please.
Hi, thank you so much. I wanted to go back to the union question. I am a member of a union, Screen Actors Guild, and I think that in my experience in working on single payer, what's happening to, and we're very excited, CTA has now publicly endorsed AB 1400, but I think that sort of like with the Democratic Party, there's a difference in the union membership and the union bosses, the union leaders. Sort of like in the Democratic Party, you'll see a difference in the Democratic members and say like the Democratic Party leaders. And so it's really important if you are a member of a union to organize with your fellow union members to lobby your union leaders to support AB 1400, and hopefully not just in name only, but really champion it. And the reason for that is there are people that are part of the union that get paid a lot of money to manage these healthcare funds for union members. And so if we have single payer healthcare, their job will disappear. Now, the nurses in writing this bill, this CalCare bill, has done a really good job of looking at, what people in healthcare industry right now would lose their jobs, say like the people answering the phones, or I don't know, doing the paperwork. And they've got places to transition them to. But there are some really high-end positions, like these positions that manage the union healthcare funds, where they're making, six figures. They're going to lose their job. They have the ear of the union bosses, so they're probably telling them a different story. And also, who knows what the union bosses are thinking. I like what Jeanna was saying. If healthcare is taken off the table, the unions are free. They're liberated to fight for more money for people, laborers. They're free to fight for whatever it is, better conditions. So anyway, I just wanted to make that point about there seems to be a discrepancy between union members and union leaders. So if you are a union member, join us, organize, and lobby your union leaders for single payer AB 1400. Thanks.
Bill, you had a...
Can I just add in, because Erica is so right. She's 110% right on this. And it brings up the ultimate irony, which is that these so-called leaders are actually, of course, followers. They follow what their rank and file, whether it's in the Democratic Party or in the union itself, membership actually wants and does, which is why it's almost pointless for us to try and beat down the doors of Jim Wood. What we need to do is to raise up awareness and work on folks in his district to raise awareness and to make it where he's suddenly on a hot seat. He can no longer accept the big money bribes of big insurance and big pharma in Healdsburg, California, and all the other cities in this district. So that's true whether it's in the Democratic Party or in unions, as you say, Erica. The leaders will follow us, and that's why we're doing all this work to raise awareness. And everybody here in this call is doing the same thing. You're all heroes of mine in that regard, is to continue to raise awareness, have forums, have movie showings, just to bring more and more of this to light so that people will finally see that. And those organizations, the rank and file membership can move them out of the way if they won't comply.
So thank you. And the next question was, so Geraldine.
I think Geraldine, yeah.
Yes, Suzanne.
Hi, Jeanna.
Welcome.
Hey, fellow Community Outreach Committee member, Geraldine Stapleton on.
Hi. Yeah, I also am a member of SAG-AFTRA, and I've been active on committees for years. And Eric is totally correct in saying that we've always had a problem because it's bipartisan and not being able to support issues. However, I did get them to pass resolutions to support the Equal Rights Amendment, but that was way back when. I was the founding member of Labor United for Universal Health Care. I think, Dr. Bill, you're familiar with that group. And our whole goal was to educate the unions and bring them on board. And I've been screaming for years, that they should take healthcare off the table of negotiations, and then the monies could be used for everything else other than that, along with John Connolly he's been a big supporter for years. I don't know whether at this point the time is right to really push that, because I know the major problem with a lot of the unions was the ERISA laws. So I'm not clear at this point just where we are in terms of being able to deal with that to make it feasible for the unions. But it is a very complicated situation in terms of the health plans. And then, of course, with what we finally got the merger through, and then trying to sync the health plans together has also been a very, very complicated situation. But I'm glad to hear that Erica's here, and that's two of us in that union that are working for this.
Or do you want to say a little bit about ERISA and the bill?
I don't have that.
No, I mean, Bill, the host, Bill, to answer
Bill.
you brought up the issue about ERISA and
Yeah, right.
I know, but Bill
I think you might have more specific knowledge as regards provisions in the bill in AB 1400 than I do, but that we kind of alluded to it before. We were talking about renegotiating contracts, and provisions for retirement, in particular. Do you know more of the details in the bill as regards that, Ron? Or
yeah, well, I do, and a little bit, and so there's a few things I guess I would mention there. Then, so one, and I always forget the constituents of this acronym, but ERISA is a federal law that, among other things, regulates some aspects of employer-based healthcare and union healthcare, and there's more details to it than that. But it tends to, in theory, sort of provide it could cause some problems or prevent certain things from being put into place. But in practice, it probably doesn't, for a couple reasons. So the bill itself specifically identifies itself as not being in a conflict with the ERISA. And then the general view of a lot of people who've been involved has been that because, so let's say your employees, or, you know, the actors in SAG being paid by the studios, et cetera, already have incredibly comprehensive health insurance that is guaranteed to them by their state. Then you might decide you want to spend some money on something else, even if you're technically allowed or can't be prevented from spending money on that. It's just redundant. And so that's one thing. Also, I guess this is sort of tangential, but in the new bill, or the new version of the bill that's a federal bill, the state-based Universal Healthcare Act, reintroduced by Ro Khanna, I thought was last week or something about that. It also looks to clarify that these things can be done and wouldn't be, and don't present conflicts. So most of us don't believe that those are practical objections.
And can I also add, because we're really going into a trench, like a Mariana's Trench of this healthcare discussion. But I want to add good discussion, and I think a lot of this is going to definitely be a lot of questions. But with AB 1400, all the opposition to this, all these deep discussions when the labor people come and, you know, some of the labor bosses who may, you know, have been talked to in other forums, I'll just say that, or, you know, politicians who are going to try to find an excuse on why we shouldn't do this. Let me tell you why this is a win-win bill. This is a win-win bill because guess what? Before we can even institute AB 1400, everybody's got to get a green light. So the board's got to give a green light. Committees have got to give the board the okay. We've got to say we've got the funding. We've checked the boxes. We were making sure we're not conflicting with any national laws. So passing AB 1400 is a win-win because it still may not even happen. So even the most person who is really disagreeing with it, if you agree with it and say, okay, you know what, I'm gonna vote yes and let you fall on your face because I don't believe in this, but I'm gonna vote yes and let you do it so that I can say that, haha, I was right, you win because maybe you are. And then the people like us who are behemoth, we know it's going to work. And so, you know, and all the sponsors and authors, we vote yes because we know it's going to work. So that's why I'm saying it's like when we start getting down these holes and going down the, you know, well, what about this situation and what about that situation? I want to pull us back up to the surface because what's in the bill really says that I can't institute this single payer CalCare program until I have gotten green lights from almost every single party involved. And so that's where I keep wanting to bring this up to this win-win conversation. Either you're going to let me fall on my face or you're going to let me change healthcare in California. Either way it goes, just vote yes.
Okay. Well said.
Very well said.
Definitely. But let me look through. It looks like, I mean, I think we're open for questions. Nobody, well, okay, I see another one from Lynn. Let me go ahead and read it. I need to read the bill, but does it address those who will be laid off under this single payer system? I'm guessing that with millions now eligible for care, there will be a huge need for claims processors. Right now, private insurance companies process Medicare claims.
I can take that because I'm one of those people. So yes, it does actually have a just transition clause in this bill where it is, you know, definitely going to provide just transition for people. Now, granted, and I think, you know, I was in a good discussion with Senator Kamlager about this just transition because yes, we do say just transition, we say just transition, but you know, what does that look like? Well, I can't 100% tell you. Can I say that, you know, I do know these insurance companies and they are petty AF. And yes, they will, as soon as this passes, say, oh, we've got to lay people off, even if they haven't lost a dime yet. This could pass and still not have gone completely full through. And they will just instantly say, oh, just because out of spite, they're going to start cutting jobs. Now, maybe we should also make sure that there is some provision about that too. But at the same time, you know, when we say just transition, it's there. And we're very well aware of what I think the companies will do. And I'm making sure that everyone's well aware of what these companies are going to do because I know. But, at the same time, it's like, we're going to be transitioning. Yes, they're going to need people like me. They're going to need people in case management, claims processing, all of that stuff. What's going to be so beautiful about it, though, is because I don't have to worry about negotiating rates. I don't have to sit there and pull the Medicare rate and know when I'm getting gouged, just what happened to me on Friday, where I had to cuss out a home health company for gouging $100 above Medicare rate per visit. That's what I do. But, that will be the beautiful thing. So things are going to be so much more streamlined. And I'm pretty sure, they will definitely be putting it out there. I think that it's going to be very important that we know sometimes the government does not come up with the clearest processes. I mean, you can just look at how to sign up for a COVID vaccine and figure that out. It's not very clear, especially in the beginning. So I think it's going to be really important that we make sure we have a very easy transition, a very, one that can be very clear and easy to follow. Go to this website, sign up here. But, and that will also be, I'm sure it will be worked out with the board and the committees once they're formed. But we got to pass AB 1400 to even get to that step. Dr. Bill.
And if I could add to that, Jeanna, which I think is really important that you brought up from strictly kind of the good jobs, bad jobs point of view, but I like to think of a single payer, starting a single payer plan for California, and CalCare is that, as a jobs bill. I mean, yeah, it provides healthcare to everybody, but it also expands the healthcare sector. So when we recover that third of every healthcare dollar that we've lost to that incredible waste, fraud, and abuse of the spaghetti chart on, the spaghetti on the wall chart, okay, we recovered. It's not pie in the sky, it's Marie Callender's pie. It's you went to Marie Callender's, bought a pie. When you got it home, you opened up the box and a third of your pie is gone. That third of your pie has been stolen. We're going to recover that third of the pie. We're going to expand healthcare, that sector of the economy, that's going to create all those new jobs, that's going to provide healthcare to all those people. So we're going to train more doctors and nurses and technicians and build clinics and hospitals for an entire third of that economy. I mean, when one hospital costs $1 billion to build, I mean, actually more than that, most hospitals, I think it's multiple billions of dollars nowadays. That's a lot of money. We're going to recover that money and provide healthcare and actually save money still, but by putting people to work. It's a jobs bill, and it creates a whole lot of healthy people at the same time. It saves money, healthy people, creates all those jobs. I mean, it goes way beyond just the good jobs, bad jobs argument, in my opinion. And you're right, Maureen, you put in the chat about the Perry study that for SB 562. That's what economists look at. They look at that expansion of the sector of the economy and what that actually means in terms of job growth, not just that kind of trade-off, but an actual economic growth factor, which will be actually phenomenal when we finally make this happen. So no doubt in my mind.
And now I want pie.
I thought, let's see, I saw
who doesn't want pie?
There was
I don't want ponies.
There's another Facebook question, and thank you again, Paul, that was more of a, it's like a kind of a political lay of the land question than a bill specific question, but let's still try to answer it. So it was from Jacqueline Hernandez, and she said, I've heard some people saying that Governor Newsom is likely to be recalled. If this does happen, would that delay or derail California politicians to pass this bill forward?
So the recall, well, Geraldine, I know you're leading that, but I'll just answer really quick. So the recall campaign is starting up. Yes, they're rolling. It's likely it'll get to their, the Republicans and the Trumpers want to fight back and blow a hole to our progressive and Democratic leadership here by taking out the governor, which they've done before. And so, yes, I'm hoping he actually doesn't get recalled and just the campaign blows a bunch of money, which is unnecessary. I think it's a complete, utter waste of time. Do I agree with everything Gavin's done? Absolutely not. Or Governor Newsom. Let me be proper here. I get too much on my high horse about we're all equal. So I call a lot of people by their first names, like you hear me call the president Joe. But anyway, but it's because we're civil servants and I feel like we should be created equal. Anyway, so I think that to me, this campaign, this stop, to me, it's a distraction. Like, I hate that this is happening. We have to come and save his ass though, because under Republican leadership, guess what's happening? It's not happening. Like, CalCare will die. And so, yeah, we got to do it. But at the same time, that does not mean that we cannot and continue to push and let him know that we have not forgotten his promise he made to us, which is you will sign this bill. I will save you, but you will sign this bill. And I need him to commit to it. I need him to really kind of say it. Like, I just need to hear it. It will just make my heart just kind of stop palpitating a little. And so I really, but when it comes to this recall, it will have to go on and we will have to probably do some fight in this. But at the same time, we are not going to be distracted. We will not be deterred. And we will continue to make sure AB 1400 makes it on his desk and it will have his signature, or I'm going to get a stamp and sign it for him. So, it's going to happen. So, but there's that. But I know Geraldine's leading the charge a lot on this, the recall, the Stop the Recall campaign. So I'll just give her a minute if you wanted to speak on it, Geraldine.
Well, just to let everybody know that it's already organized, Stop the Republican Recall. I think we're, just like Jeanna's already said, the outcome of losing Gavin to a Republican governor would be a disaster for what we've got going right now. This is the best opportunity that we've had in many, many years to finally get this to a governor's desk and get it signed. So yeah, if people are concerned, you can contact me through Jeanna or whatever. There's a state campaign, the state parties campaign, the local county committees campaign, and DipSIF, the Democratic Party of San Fernando Valley, which is the one I'm co-chairing. So yes, to answer the question, it could really affect it. So we need to put a stop to it. And I like Jeanna, I don't agree with everything that's been going on, but certainly we don't want to see the outcome of if he was to get recalled and end up with the Republican governor.
And Dr. Bill, and then please respond to that, and then we'll go to Erica's stacked.
So just a quick addition to that. Gavin Newsom, may consider himself a progressive, and he's not my kind of progressive, but what is a progressive? I mean, a progressive wants to make progress. A conservative wants to keep things the same or even take us backward. And I think the Republicans are in that business of keeping things the same or taking us backward. Some Democrats are too. They like the status quo just fine. That's what got them in office, as far as they're concerned. I think it remains to be seen when we go into the committee process with AB 1400, we can get a vibe, we can get a sense. I'm discouraged at the fact that they stopped the committee, the Healthy California for All committee that was supposed to take place. Here we had a state public health emergency, COVID, and they shut down the very committee that could have got us out of it, that could have got out of the public health committee. The governor shuts down the committee that could have, addressed that. Saying, oh, we're too overwhelmed with COVID. No, that's the reason to have the committee hearings. We're all having meetings on Zoom. Why couldn't they? So as far as I'm concerned, I'm very discouraged in that respect. This is an opportunity for Gavin Newsom to lead his way out of the recall at this point. We will all fight against the recall. There's no doubt about it, because that will certainly set us back. But it's also an opportunity for him to actually lead and push the assembly forward. I'm not, holding my breath on him doing that. That's why, to me, it's all about what we here in this room do to push the narrative forward.
No, very good. So more questions, and I want to continue to, and as much as like the political context is important, I just want to focus us on the bill itself. What does this bill do? How is a single payer system and the one described in AB 1400 different than what we have? Who would be covered that isn't covered right now? All those questions are so basic to what it is that I want to make sure we're hitting on those. But of course, any questions that anybody has, but let's do bill questions.
All right, I think Erica still had a question.
Oh, sorry. Oh, of course. Sorry. Okay, Erica, please.
Yeah, mine was a little bit on the governor, but I want to make it about the bill. And just hearing what you said, Dr. Birnbaum or Ron, one of the things that this bill does is it, Patrisse Cullors from Black Lives Matters talks about shifting from an economy of punishment to an economy of care. And this bill, CalCare, is a huge shift in that direction. People are punished if they cannot afford health care. They lose life, they lose limb, they lose their economic foundation. So that's one of the things that CalCare does, is it starts to shift us from an economy of punishment to an economy of care. And I just want to say, on the political end, Jeanna, when you talk about, Gavin promised to sign this bill. Actually, this bill didn't exist. What he promised was to give us single payer. And I'm grateful that the nurses have written CalCare to have a bill for him to sign. But instead of thinking of it like, well, if it passes this and this and this and gets to his desk, there is one person that has the power to make this bill happen. And it's not Jim Wood. It's Governor Gavin Newsom. And if he stood up there and said to his supermajority Democratic legislators, I want CalCare on my desk, they would say, yes, sir. And it would be done. He has the power to do this. And as Dr. Bill said, if he does that, he doesn't need to think twice about a recall. Because we saw how Bernie Sanders won California huge. That is the kind of rallying power he would have for governorship and probably beyond. So I thought that was important for the bill. That's like, we could skip everybody else and just go right to the top. And I used to work in sales, and that was what I was taught in sales. They said, never talk to the people who don't have the power to say yes, because they only have the power to say no. Get to the person who has the power to say yes, and that is who you pitch for your sale. Don't waste your time with anybody else. So Governor Newsom does have the power to say yes, and CalCare now.
Thank you, Erica.
So, go ahead.
Well, one thing I wanted to say about just the office hours is, and what I thought about, what we're doing this for is also an each one teach one type thing. So, we do this to answer the questions about the bill, and we do get into some good discussions. I love these discussions, especially, regarding a lot of the kind of nuanced things that will be affected by CalCare. But with each one teach one, I don't know if you know the origin of that, but it goes back to slavery, when we weren't allowed to learn how to read and write. And so each one of us, whoever learned how to read, would teach the next one how to read and how to write. And that's what these office hours are for. So we're trying to be there to teach you so that you can go teach someone else. While yes, Governor Newsom he does have the power, but so do we, because guess what? I really don't have the number. I don't have his number. And as much as I would have a quick 30-minute conversation with him in and out to just, have this, but, I really want to just emphasize that it is still so important that each one of us go back to our networks and teach about this, because when the misinformation train really starts rolling, we need to make sure that everyone in our communities is properly inoculated with the truth. And so then I see another question.
Yeah, I'll read it. It comes from
I lost it. Yeah, go for it.
It came from Chris Shimizu, a very committed activist from Healthcare for All, Los Angeles, and also a member of the County Democratic Party. She asked, does AB 1400 cover medical marijuana?
Yes.
And yeah, there you go. I could give you a couple of slight pieces of color to the succinct answer there. The answer is yes, and the bill intends to cover things that are medically necessary. And I think that falls squarely, and that judgment is between primarily providers and their and patients. And it does have a list of some things that it says, for example, that the board will end up having to decide if that would be covered or not. I'll give you an example of that. But things that aren't on that list, I think, are kind of, they're implicitly covered based on the general provisions. So one is like diet and nutritional interventions. And so, I, as a doctor, for example, could say to my patient, you would be much happier if you had a lobster and a steak every other night for dinner. And guess what? We can send the bill for your lobster and steak to the state of California. And that wouldn't be covered unless the board looked at that and said, that's something we really want to cover. But for example, there's plenty of nutritional things that do need to be covered. People who need, liquid,
like the insures, and
like so anyhow, just to kind of flesh out a little bit of things that may be at the borderline, but I don't think medical marijuana is now.
Well, I mean, I don't see a direct reference to medical marijuana in AB 1400, but it doesn't mean that it couldn't be. But when it says medical, I mean, I'm talking truly medical, not recreational. So it would be, you would need to have a progressive physician, because now we're going to get into more of the healthcare, like I don't want to say employee, but like overall just how we do healthcare in America. And when I say you're going to need a progressive physician, because there's still not, a lot of doctors don't believe in medical marijuana, nor will they prescribe it. And so, you're going to need a pretty progressive doctor to say, you know what, I'm going to treat this with medical marijuana. I'm going to treat, instead of just giving you some type of pharmaceutical medication. And so that's a whole nother issue that, like I said, CalCare would then, having access to care will then let us focus on how we administer that care and the training and all that stuff that comes along with it. But I just want to kind of really emphasize that, because I don't want people to think that, oh, with AB 1400, I'm gonna go get my moon rock and my dab and blah, 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 blah. And I'm like, unless you got a really progressive doctor, you're not getting it. But you could possibly get, I think if you had the right physician and you had the condition and it checked, I think you possibly could. Nancy, did you have something you wanted to chime in on that? I saw you.
Yeah, I'm really bothered by the idea of politicizing medicine. There is science behind what marijuana does and doesn't do. And I don't think it's about a progressive doctor. It may be a doctor who will agree with you or will let you have it. But I like to think that I make medical decisions based on medicine and not my politics.
Well, no. When I say progressive, doctor, let me clarify. I don't mean progressive politic. I mean progressive thinking. So a lot of physicians, and I can name 50 off the top of my head, who do not still believe in the science of medical marijuana. They're just kind of stuck. And when I say progressive, I don't mean progressive politic. I mean progressive forward thinking that will actually appreciate that science, because I really do appreciate science. I'm actually into the psychedelic world on the science now. I'm beyond medical marijuana. We're going into the psychedelics now. But at the same, so just to clarify, when I say progressive, I'm not saying like, oh, they voted Bernie Sanders. I'm saying progressive, like they actually are open to trying these new treatments that have been, completely peer reviewed and shown to have scientific to be scientifically sound, and they just are not quite there yet.
Let's be clear, the science is mixed. Marijuana does some good things, and there's some really bad things about marijuana too. So I'll leave it there.
So if I could just qualify my curt answer of yes, just to say that that the bill covers acceptable medical practices that are evidence-based. And that's my interpretation of reading it. I don't know, Ron and Jeanna, if you want to, if you have more specific references from the bill itself. But I think that's true in this bill, the AB 1400, as well as the federal bill, that if it's considered acceptable medical practice, in other words, if doctors are allowed to prescribe marijuana in the state of California, which I believe they are, then that would be covered, and in under CalCare. And that's actually not a financing issue, which is what CalCare is all about. That's a medical board issue, which is, authorizes what kinds of treatments are acceptable, what standards of care are, that kind of thing. So that there are provisions in this bill for the CalCare board to interface with the medical board of the state of California. So that's exactly where they have to interface that way. And Dr. Nancy Nabargo is quite right. There can be mixed evidence over lots of medical conditions, but when it's considered to be an acceptable practice, then the board allows that to take place. Once it's considered acceptable under the board, then my understanding is it would be provided by AB 1400 for the state of California, or Medicare for All under the federal bill.
And let me then follow that up with a question that Lynn asked, because it's sort of related about, in some ways it gets to formulary and expensive type services, right? So the question was, does AB 1400 cover expensive services like transplants, designed drugs, and overpriced medications? So I read her question verbatim.
So I just will add, it will, but when we talk about, going back to things approved by the board, like they're going to negotiate. Like the good thing about having single payer is it gives us so much bargaining power. We are going to have tremendous bargaining power bringing these drug prices down. I mean, do you know how much they pay the people that just name these drugs, the things we can't pronounce? Like, I can't even, I found out like some of these names, you get paid like a six-figure salary to just create a name that literally makes no sense. And so, that bloat, like it goes back to the basic principles, that bloat, that's part of the bloat, that can go away. And bring these drug prices down. And what I like about, negotiating these drug prices for, there's this, there was an experimental antibody treatment that we're trying, and we call it the BAM therapy. It's one of these things. I don't know, Dr. Bill or Dr. Birnbaum, it was like bamlanazumab, something like that. It was for COVID. Yeah, it was. Yeah, you know what I'm talking about. It was like something BAM.
It's a monoclonal antibody for.
Yes, it's an antibody, but it had this really long name. It was really expensive. It was experimental. We found out it really wasn't that great. So actually a lot of people stopped using it. And I looked at the cost of that. I asked because I was curious. And I think it was something around, and it's just a one-time treatment. And they were like, oh, it's about maybe $3,000. One-time 60-minute infusion, $3,000. Now, granted, it's experiment. It was covered. I don't think anybody got a bill because this was kind of like an experimental thing. But still, $3,000 for a 60-minute infusion. And so that's insane. And, and thankfully, like I said, it would be covered. But at the same time, right now, chemotherapy agents, when a lot of health plans see you get that kind of experimental clinical trial chemo, you know what they do? They're so quick to click deny on that. It is ridiculous. They get happy to deny that stuff. But under CalCare, I think that, and I actually need to go back and look and see, clinical trial medications, how that is worked in. I believe that's one of the things that get deferred to the board to decide. Once CalCare is passed, the board has a lot of work to do on making these kind of these decisions that get into the weeds. But, I think that if there is a clinical trial going on and it's showing to be successful, and has good outcomes already, I mean, I would hate to think that they would deny something like that. But, I believe honestly in the bill, I believe a lot of that could be possibly deferred to the board once they're formed upon passing. Dr. Birnbaum, Bill, if you guys have a more direct clarification.
So I'll say a couple of things about that. So one is that the bill does describe that the plan has to establish a formulary. And as Jeanna was mentioning, and so that still then involves at some level making judgments about things that are just outside or maybe just inside the evidence line and that kind of thing. And the thing though is that, so everybody knows right now that a lot of decisions like that are being made not at all based on medical necessity, but based on the bottom lines of insurance companies who don't care about whether, those things. So I don't think that any health system or plan can get around the formulary question, right? But at least that it's being done by not by people who are trying to making profit from the decision making in that. It is absolutely the case that both theoretically and in the kind of literature on how countries and polities that have universal healthcare systems spend less, one of them is that they are able to get better prices on drugs. That's an important part of the savings. And so the word, one person's overpriced drug is another person's like life-saving essential drug. So there's a judgment in the word what overpriced means, but it is the case that the ability to bargain those prices down makes a huge difference on saving. So that would be. Can
I just add? I was looking it up in the bill because I was kind of curious. I was going kind of like second guessing what I initially read. But part of the board, they are there to establish the drug formulary. So that is on the board. That's why the 9-person board, I would like to see that 9 increase a little bit because throughout the bill, there's a lot of weight put on the board and the committee. But anyway, but it does say in AB 1400, I'm looking at it through a PDF, so I'm not sure. It says, I think it's on page 52. It's like the first sentence. It says to establish the prescription drug formulary system, the board shall do the following, which is number 1, promote the use of generic and biosimilar medications. So no, big fancy name medications. Consider the clinical efficacy of medications.
Actually, I want to stop you there because I actually think that that's incorrect to say that there would be no big fancy medication.
Well, I meant, clarify that one.
And because there's too many people in the world who are getting care for cancer, care for immunologic diseases of various kinds, rheumatologic diseases, for whom new technology type medications make a very important big difference. And I don't want people to come away thinking that somehow there would be a big technologic step backwards because of this bill. That's not correct.
Yeah, thank you for that clarification. And then Sorry. Oh, okay. And then, and then update the formulary frequently, which is very important because just like, Ron said, medications, they come out, they're usually patented, especially the updated, like frontline, kind of on the frontier medications, they're patented. But, that patent goes away after a certain amount of time. So updating this formulary frequently means that we can, maybe get that medication, down, the cost down after a certain amount of time, and allow healthcare professionals, other clinicians, members to petition the board to add new pharmaceuticals or to remove ineffective or dangerous medications from the formulary. So if there is a new frontier medication going out right now that is not generic, just like Dr. Birnbaum was saying, we can petition the board and say, this medication it could basically revolutionize and cause, great outcomes for my patients without maybe the side effects that this current treatment has. And, he can provide a petition and petition the board to add this medication to the formulary and also remove ineffective or dangerous medications. For example, I'll use hydrochloroquine, for example. We had this whole hydrochloroquine thing that went down and, Trump was pumping it out and everyone's like, I want hydrochloroquine for, to treat COVID. And we found out, oh crap, it's actually not really that good for you. We can remove that. Dr.
I'm gonna. So it turns out hydroxychloroquine, not talking about for COVID, is in very wide use for rheumatologic disease and dermatologic disease, and is absolutely an essential medicine. And that was an example of something that got highly politicized.
Right,
so I'm not talking
Sorry.
about the COVID thing, but actually, I'm just going to say that again, which is I don't think that we don't want these decisions to be made by like the news media and the this and that, and so
Can I
Bill, I know you wanted to say something. There's a question that Sean had asked a while ago, so I wanted to make sure.
Okay, sure. Go ahead, Dr. Bill. And then we'll go to Sean.
Just real quick, and when people say real quick, it's never going to be real quick. But I just want to address something I call formulary phobia, which is I know they're not both spelled with F, one spelled F, anyhow. But I actually think that's something that Kaiser and large group practices do very well, and that includes like teaching facilities and things. They actually develop formularies based on evidence, scientific evidence, to come up with what they think are the best pharmaceuticals and other kinds of care, that they provide to people. And in the good sense of the term, health maintenance organization to keep people healthy. What a concept, right? So we did that when I was at Kaiser. We did that in pharmaceutical and therapeutics committee. We sat down in committees and we excluded drug detail people. They were not allowed to come into our committee meetings and try to influence us with their spiels and stuff. We didn't have Donald Trump telling us that, the latest, greatest thing that he got when he was at Walter Reed. So, so I think that that means a formulary decided upon by a group, the board or whoever it is that the board decides, can be a very good thing. And then that makes for good pharmaceuticals and therapeutics that are proven to help people more than they hurt people and end up costing us less at the same time as provide better care. So
Sean Broadbent had a question that was a little bit while ago, and he called it a basic question. And I'm going to use that in a good sense, not in the current pejorative sense that the word basic has gotten, which is just kind of a basic question. So how soon can I get a CalCare insurance card once the bill is passed and signed by the governor?
So CalCare, like I said, CalCare is a key of many keys. It's like, I use this, I think, I don't know, yesterday, the whole world is blurring together in timeline, but it's like the key to the front door. If you have like a front gate, you've got to open before you get to the key to the house, you've got to unlock that door. So, it could be, I don't want to discourage people, but, CalCare, like if he signs it, the next day CalCare is not there. Like I said, the board has to be formed. The committees have to be formed. They all have to green light this saying, we've got the funding. We were able to obtain the waivers. We were able, and we can show that we're going to be able to fund this for a period of time. And that, you know, we've got everything basically in order for this to pass. And I can't promise that that'll happen in just a year or 6 months. That may happen in a couple of years. So by the time you get your CalCare card, it may be a year, it could be 2 years, but let me just put this in reference. They've been fighting for this like since the 90s or before. I mean, I don't know if there was a bill before the one that came out in the 90s. And think about that. We could have had this train rolling so smoothly by 2021 if people would have just been on board in the beginning. But now, you know, so I mean, maybe we'll see this, if we pass it this year, maybe we could have it up and rolling by 2024. You know, and I think that's a realistic timeline because there's a lot that has to be put together, mainly obtaining those waivers. And then there's going to be a lot of people who, even after this passes, that's when it's really going to get ugly, because now the insurance companies are really going to be trying to save themselves. And so, you know, I just want to emphasize that passing CalCare doesn't mean single payer tomorrow. Passing CalCare will actually give us the chance to build it. We've never gotten a chance to build it. It will actually give us that chance.
I am even more optimistic, and I don't see what keeps us once we get the funding. I don't see anything keeping us from being able to roll it out within 1 year of its passage and signing, frankly. So I think the whole thing can be done within 1 year. And when you consider national Medicare was rolled out within 1 year, basically, and fully implemented, you know, within 3 or 4 years, you know, and that was before they had computers. You know, I don't see why. We've got the mechanisms in place. They just need to expand those. And we're talking about simplified systems, not more complicated, much less complicated and streamlined, standardized, unified. All that to me means much more quickly. For example, there's no enrollment. No, got that? Everyone got that? You know, no enrollment. What is enrollment? I mean, you know, people in Canada and Taiwan, they look at us like we're crazy. You have to enroll in you know, for your health insurance. It's ridiculous. You know, we don't need enrollment. If you live in the state, you go to seek healthcare, you can, you know, show your utility bill from, you know, that shows your street address, and, you know, other ways to substantiate that you reside in the state, you know, which they will post, you know, they will let known, they'll make public. You're in, that's it. You can go, you can present that at the point of service, and no enrollment was required. So I think the stumbling blocks and everything that we're all used to that make us estimate that it won't happen for 3-4 years actually disappear, and it could happen within a year.
Very good point. Very good point. And like you said, you brought that up, and that sets precedents too. So, you know, like you said, they did this before computers, and that's when they had the Dewey Decimal System. So if they can do it with Dewey, then we can do it with Apple and our computers. So I think that you just gave me a very good talking point, and thank you for bringing that back up.
Weren't those Donald Duck's nephews, Huey, Dewey, and
I forgot the other one, but yeah, the little DuckTales.
Dewey, Louie.
Louie, there we are.
Louie, Huey, Dewey, Louie.
And my husband's name is Dewey, so watch it.
So Betty, Betty had a question, and if you unmute Betty, you can say it, or I can say it.
Betty.
Yeah, sure. I'll ask my question by myself. This question is to Dr. Bill. And I wanted to know, will we be able to bulk negotiate pharmaceuticals under AB 1400? I hear that Medicare cannot do this right now. So I'm just kind of wondering if we'll be able to do that with AB 1400.
Yes. Next question.
Medicare can't, because there's a law that says Medicare can't, but there's not a law that says that CalCare can't. So the next question, but that's a good answer.
It just, I'm being a little facetious just by saying those curt replies, but it's a great question, Betty, and thank you. The fact is that the state is negotiating it on our behalf. So you and I no longer have to go into a pharmacy and, figure out if we can afford our prescription, right? So the state does that for us at that point. The CalCare board does that for us. So that's the point of negotiation. It's not you and me anymore, deciding if we're going to buy the prescription or have food on our table or pay the rent anymore. So it's just a sea change, culture shift, that will take place, and talk about freedom and liberation, so yeah, and Ron is right. The state can do it. We can't necessarily. I mean, the VA does that. So this basically gives California the same capacity that the VA would has at present to negotiate drug prices.
So then Lynn had the next question. Do you want to unmute and ask, Lynn? You're muted, or I can. Lynn, either unmute or I can ask the question for you. Let me ask it for you, but if you unmute, you can chime in.
Sorry, it's my laptop and my mouse. I'm envisioning that the insurance companies in California have billions of computers with and computer systems and information, etc. How do we transition from the info on all their computers to single payer computers?
I could, yeah, if you go ahead. If you feel stuck, let me know. Yeah, I have some thoughts on it.
No, Ron, if you have a more direct answer, I mean, I know I read about like having to report back, to CalCare, but that's from the provider side, but transitioning that information with the plan. I mean, at the same time, the plan isn't the one that holds your medical records, okay? They just hold, I don't want to say we, but we hold your insurance information. So your eligibility, your benefits. So when I go in and do a benefit search for a patient, do you have this benefit? That's all that shows. It'll show your coverage, when you're covered until, what benefits are covered, your co-pays, deductibles, et cetera, et cetera. Your medical records are held with whatever your provider is, and those providers shouldn't go away. So it should continue on, just like that. But your insurance information, honestly, the only thing your insurance has are the claims that have been submitted to it, and maybe some supporting documentation for that, and then your benefit information. But when it comes to your medical records, that is really held with your provider.
Yeah, so the insurance companies will just basically have to shut down their systems.
I'm telling you, they're going to find a way to get themselves into this. They did it with Medicare. I know they pay people to do this stuff. I honestly am not paying the world's smallest violin for them quite yet. And I work for them, so I know that they're going to figure it out. They'll be fine.
They're gonna find something else to do with medical liability and car insurance too, and
Brazilian butt lifts,
and workers' comp too. They're going to have to find something else to do with all those insurance records. But Jeanna's absolutely right. I mean, your medical record is held by your medical provider, not by your insurance company. So that will still stay there until you change provider. Right now, your provider is not allowed to share that with other providers necessarily because of insurance companies telling them that they can't. I mean, there are proprietary restrictions to sharing your medical information, even among other providers. And, some of that, I mean, there are privacy laws too, but they're also proprietary. Even if you wanted to share your information with other providers, you may not be able to. And that's a big reason why we can't respond in the case of a public health emergency, is that our provider groups can't share information due to proprietary interests of insurance companies at this point. That's why Taiwan has done phenomenally well, and South Korea has done phenomenally well, is because they share that kind of public health record, between provider groups, and they've been able to track COVID where we haven't been able.
I would say, as with relationship to the bill, I agree with everything that was said, which is that, even if you just switch your health insurance from Blue Cross to Aetna, there's nothing that needs to go with you from Blue Cross to Aetna. So insurance records and health records are two different matters, as Jeanna was very carefully laid out.
And then I can also add, when you're like, for people that come into my group, I have no idea where you came from. Like, I don't see your past insurance history. I can't. So the only way I know what insurance you had prior is to come and ask you, like, oh, well, what group were you with before this? So just to clarify that too.
So the bill, let me say this, the bill does talk a little bit about electronic health records, but it's kind of light on details about it. The biggest thing that it talks about is essentially banning one way that health records are sometimes used by plans, which is to put in place like guidelines that for care provision that can't be overridden by the person who wants to provide care in a case where there's an important exception. So it bans that, but on the whole, which is a good idea, but on the whole is pretty light about details about electronic health records. But I think, as Dr. Bill was saying, that a single system provides, in theory, an incredible opportunity for really good things to come from some record integration and interoperability, savings from non-duplication of tests, for example, or a whole bunch of other things, just ease of getting records, which sometimes records are hard to get, not because a provider or a provider associated with the plan doesn't want to make it easy for you to move from a place to another place.
Or it's just the system in general. Like, I mean, sometimes I have to go to an out-of-network hospital to ask for records so that we can continue care for a patient that's in another hospital. And it's like pulling teeth. I mean, you would think I'm trying to unseal some kind of like CIA document sometimes. Like, I've got to submit a letter on official letterhead with my signature and my credentials, everything, just to get a test result so that we can continue taking care of you wherever you're hospitalized right now. So imagine the delay in care on that. I've been advocating for one single EMR, or electronic medical record, since I think we went electronic in the 2000s, because I'm like, can we just have all Epic, please, so that I could just log in one thing and look at it all at once. But granted, we're probably far away from that right now. I don't want to go down there, but that also creates the delay in care and contributes back to Dr. Bill's spaghetti.
And I want to follow up on one thing about the bill itself. And so one of the organizations that's a sponsor of this is Physicians for a National Health Program. And it has also undertaken like a look at some of the issues in the bill. And this is one where at least there's a conversation about seeing this as an opportunity for strengthening the bill in terms of the kinds of things that you just heard about, interoperability and unification of health records as a streamlining of care mechanism for patients. So let's see, are there questions? Carol had let's see, was there a question before Carol's? One, but let's see, I don't think so. So Carol, do you want to ask your question?
I put one in from Facebook.
Oh, okay. Sorry, go ahead.
Oh, yeah, I saw it now from Linda Teach. Yeah. She said, isn't our government paying for the COVID technology? Haven't these companies increased profits tenfold or by some huge number? Don't we de or is that in fact or defect, have healthcare for all now, where private companies are making enormous profits for the government, where that the government is paying for? Ooh, snap, snap, Linda.
Yeah, well, so actually that's an interesting question then. Let me borrow from her thinking there, which is, how does this bill change for-profit provision of healthcare? So providers where profit is part of the story.
I mean, so yes, I mean, this actually, the COVID testing, and I've seen the meme about this actually, when you go and get your vaccine and your COVID testing, actually, I know I did all my COVID testing through the county, and they do ask you if you have insurance, right? They say, do you have it? Do you not have it? Now, granted, it doesn't matter, but if you have it, they do ask you to put your insurance info and et cetera. Never received a bill. But yeah, that could be a straight up preview of how single payer will work. Like I went and got my swabby up my nose, got my COVID test, no bill, no payment, and I just kept driving through. I went and got my Moderna shot twice, no bill, no payment, no request for payment. And I'm, so I mean, maybe could be actually a little bit of a preview. They just sacrificed. They just completely just shot themselves in the foot and just gave us a preview of what single payer healthcare would look like.
Absolutely true. But they totally dropped the ball on testing, because we should be doing testing on a repeated, regular basis at this point, and universally across the board. I mean, I know the nurses in California had to fight like hell to get the California Department of Health to require hospitals to test hospital workers. I mean, hospitals were not going to do it. And that was because they weren't getting, grants or funding from other sources to test hospital staff, hospitals where we've entrusted the care of our COVID patients. That's where our worst COVID patients have gone, and our hospital workers were not being tested. So somewhere like South Korea, where when COVID first started, they were testing everybody, and they repeated their testing. Somewhere like Cuba, where they have social workers that can survey the entire island, within a matter of days, if not hours, can survey their entire island nation and find out exactly the status of people. And that may be considered by some to be an intrusion, but when it comes to public health, that's what you need to actually handle something like this. So we, again, this comes with the concept of not just for profit, but profit first. If these companies, like the ones who were making test kits, did not see it as being profitable for them, they weren't going to do it. They're not profit first. It's not a win-win-win for Donald Trump and his buddies. Then they weren't going to enter into universal testing. They weren't going to enter into contact tracing, because there was no profit in it for them. So you're absolutely right, Jeanna, that the vaccines appeared to be fantastic. It gave people a glimpse at what it means to be free. Treatment is free at the point of service, but that's just the very tip of the iceberg. And they could be kind of pulling us into this false sense of, oh, well, see, the system is taking care of us, but they totally dropped the ball on testing, because we're nowhere near at universal testing, which we still should be doing. I mean, look at this fourth wave of COVID that's going on now, right? Contact tracing. And still, are we providing all the PPE that our frontline workers need? Are they having to reuse masks, or use the same mask all day, instead of one mask for each patient encounter, like we know they're supposed to? So all of that, is something that the CalCare board can address. Right now, it's up to the goodwill, quote unquote, of these profit first corporate entities.
Can I ask a follow-up question related to the bill, though, on that? I mean, you were answering related to the bill, but which is, how does the way the bill describes reimbursing providers of healthcare, so institutional providers and sort of individual providers, how does that change profit motives among those providers?
Why do I get the sense that you know the answer to that question that you're asking?
I get, sure, I'm not trying to be squirrely. Like the answer in part is that there are, it's so funny, the bill does some things that are fundamental to contemporary single payer bills, which is it designates two kinds of providers: institutional providers and sort of individual providers. So an institutional provider, an example would be a hospital, simplest example. And an individual provider would be like a solo practice doctor in an office, just another single example. There's other types of examples of both things. But for the institutional providers, Linda, if you're out there, it does what's called global budgets. So global budgets or global budgeting is more like the way we budget for the firehouse on the corner, or for the public library downtown, or any institution that has to have money to operate and has a somewhat predictable set of things that it needs to do, and then it gets one pot of money a year to do it, with the possibility, if there's special circumstances, to modify it if there's a pandemic that changes big things. And that pot of money doesn't include a line item for profit. And that can't be in the budget. And so it essentially eliminates the for-profit provision of healthcare in California. It then addresses, to some extent, what happens if an institution ends up spending less than it was given in its budget, and therefore there's sort of a margin of money, that's the exact word used in the bill, left over. And the answer is it's allowed to use that money, but it has to be for the care of patients. It can't be used for lobbying. It can't be used to pay bonuses to the executives. It sort of limits some of those things. So
Can I add one thing, Ron?
Yeah.
This is not rocket science. It is science. It's hardcore economic, social science. It's not rocket science, but it's health policy science. And it's the way things operate now, on a smaller scale, perhaps, but like with the VA system, with Medicare for seniors, that's the way it works now. At least traditional Medicare. So we're not talking about reinventing some wheel or some brand new thing. We're talking about using models that exist, and they work very well and will save money. And lots of economists, have bought into it. So this is not magic. This is established science.
Carol Federa had a really good question. Would you want to ask your question? And Bill, you gave a partial answer. I mean, not a good answer in the chat, but I think it's worth hearing that.
Sure. Right now for our auto insurance, we have medical liability costs. So in case we're in an accident or cause an accident, what would happen to that at this point if we got CalCare?
Gone.
Okay.
I mean, you also pay for medical liability for homeowners insurance and business property. And if you're a renter, that's part of your rent. You're paying for that too in your rent. That's gone, and that's factored in again by economists. They factor in that, what are people paying for, for property, medical liability in their property insurance. There's also, as we've brought up before, malpractice, medical malpractice. In single payer countries, they have half the medical malpractice that we have. Why is that? Because they have completely open access to seeing their doctor, and they've built trust, and they have a relationship, and you're not going to sue somebody that you have a relationship with usually. So they have that built trust. They have half the malpractice. That means they practice half of the defensive medicine that we do in this country, where doctors overorder tests and treatments that actually can make people worse. So all of that is factored in too into those incredible savings. And again, it's not magic; it's science.
Can I,
Sure, Nancy, you
can I
have.
ask something? Thank you. I had never heard that, Dr. Bill, that malpractice goes down 50%. I think that's a great answer to the question. Partial answer to the question I was going to ask. I've gone to PNHP meetings for many years. And a few years ago, I had 2 kind of big surgeries in a year. And my surgeons would not even hear of the word single payer or Medicare for all. And I think the elephant in the room of all the PNHP meetings I've ever been to is that there are few, if any, surgeons ever there. So I really strongly think that the devil is in our own home, and that we really need to be addressing this profit motive of the people next to us, our colleagues, who are doing well in the current system.
Yeah, a little too well, you might say. So, and I've given those PNHP lectures too, or borrowed their slides with permission, stolen them with permission. Anyhow, so I've given those slides, and they've got the data like from Canada as to what doctors make in Canada, the income based on specialty. And, when I show those slides, if I show them to primary care doctors, their jaws drop, because they make like twice as much. Family doctors, pediatricians, basic OBGYN, psychiatrists make like twice what doctors in this country make. They make that much in Canada, whereas surgeons make half as much in Canada as they make in this country. So you're absolutely right. And, why is that? So, and frankly, I don't know about you. I don't know what an ophthalmologist actually makes in this country. I mean, that's actually a secret. It's a trade secret. In Canada, a lot. Right. Enough for more than one Ferrari, right? So it's like, why do you need more than one Ferrari? But it is a lot. It's actually too much. The reason is that it's fee for service. It's the fee for service part of medicine where they're actually, charging by the stitch or by the procedure. And that's the opportunity to rack up the charges, whereas doctors who aren't doing those kind of procedure type medicine, probably are spending a lot more time just talking, relating to patients, that kind of thing, like in primary care. But, I know we've got Dr. Ron Birnbaum here with us, who does a lot of procedures in his practice too. But I think that's why, it's surgeons in particular who have kind of capitalized on our system being the way it is. And, some of those specialties are especially egregious, but they still do very well. I mean, like is $600,000 a year enough? Because that's what they make in Canada. It's, an orthopedic or ophthalmologic surgeon in Canada makes that kind of money, and that's in US dollars.
Shouldn't we have a plan?
Because we have to,
Okay.
we're at the end of our time. I'm not going to, although I do want to just point out that CalCare does continue to do fee for service as its main methodology for the individual provider. So I also want us to have fidelity to what is in fact in the bill. But I really want to stop and thank everybody who came together here to learn more about the bill and this process. To thank everybody who's on Facebook, who's been asking great questions. particularly thank Paul again for transmitting those questions. Stress that, and then of course my co-hosts today, Jeanna Harris, RN, and Bill Honigman, MD, for their wonderful answers to these questions. And then just tell everybody that this process continues as the bill process continues. So we will be back here at 5 p.m. next week. And I hope you will all encourage others to join us and join us again yourselves.
And remember, each one teach one. So take what you've learned and go teach somebody else. That's the only way we're going to win.
Super. Thank you. Final thought, Bill?
Yes, and drag them all in here. Tell them office hours, yes, we're open. A flashing sign, yes, we're open every Sunday, to talk this stuff. So we just love talking this stuff, don't we? Thank you. Thanks for being here, everyone. Thanks for having me.
Okay.
Good night.
Night.
See y'all. Stay well. Be well, right, Maureen?
All right. I'm going to hop off too because I literally hope I'm not burning my food. Bye, guys.
See ya.
Thank you, guys. Fantastic.